Hello, everyone, and welcome. Thank you so much for coming today to our webinar. We're here today because it is National Infertility Awareness Month. And you know what? We want to talk about infertility because it doesn't get talked about enough. So we are here today to talk about our lived experiences. And we also want to acknowledge the environmental causes of infertility, the stigma and the lived experiences of women with specifically polycystic ovarian syndrome and Turner syndrome as two examples of conditions that can cause infertility. So thank you so much for joining us today. And next slide, please. So the views expressed in this webinar are solely those of the speaker and do not reflect the official policy or position of the U.S. Department of Health and Human Services or the U.S. government. Next slide, please. And to cover just some housekeeping, the question and answer session will take place following the presentations. Throughout the presentations, please use the Q&A feature to send questions to the presenters or put them in the chat. Please put your questions in the chat. Presentation slides along with a list of resources will be sent to all registered participants shortly following this webinar. We ask that you complete our feedback survey after the meeting. The link to that survey will be placed in the chat here momentarily. Please take a moment to fill out our survey. Everything that you say in the survey is anonymous and will contribute to us having even better webinars in the future. And lastly, of course, thank you for your participation. We are pleased you are here. We're really looking forward to this very personal discussion on infertility and how it affects the lives of so many women. Next slide, please. Now, it is my distinct pleasure to introduce Dr. Vicki Sutherland. Dr. Sutherland is a toxicologist for the Developmental and Reproductive Toxicology group at the National Institute of Environmental Health Sciences. Following Dr. Sutherland's presentation, we have Angela Grassi. Angela Grassi is the founder and director for PCOS Nutrition Center, and she is a professor at Westchester University. Finally, we will hear from Dorothy Baum, who is the North Texas branch support group leader as part of the Turner Syndrome Society of the United States. So now it is my pleasure to turn the floor over to Dr. Vicki Sutherland. Dr. Sutherland, take it away.
Thank you. And thank you both to you and to Chris for the invitation to speak today. So next slide, please. So what I'd like to do is try to give you just a very brief introduction to endocrine active chemicals, infertility, and the environment. Next slide, please. And to do this, I think what I'll start with is kind of just a very brief overview of the endocrine and reproductive systems and some of the hormones of interest, as well as talk about the reproductive life cycle and sensitive windows and impacts on that system.
Hi, Dr. Sutherland, I'm sorry to interrupt, but could you speak up a little bit louder?
Oh, sure.
Thanks.
Let me try and get a little closer to the microphone.
Thanks.
Okay, so in looking at the impacts on that system, potentially from environmental factors, such as we'll be discussing today, and then of course, touching on infertility. So next slide, please. So the endocrine system is a series of glands and tissues that produce and secrete hormones. These hormones are used by the body to regulate and coordinate vital bodily functions. They include everything from, say, growth and development, metabolism, sexual function and reproduction, and even sleep and mood. Essentially, hormones are responsible for regulating and coordinating physiological processes and maintaining homeostatic balance in the body. Next slide, please. And the reproductive system is essentially part of the endocrine system, as the reproductive organs and functions rely on hormones for all life stages for both males and females. Next slide, please. And while most every organ or body system uses, creates, or is impacted by hormones, I've listed here a number of the primary hormones, target organs and functions that may be of interest for today's discussion, with those in blue primarily associated with the reproductive system. And while we're not going to discuss them in detail, they're here as a reference for those that are interested. Next slide, please. The main point that I want to bring up is that while reproduction focuses primarily on the gonads, any disturbance in any of these hormones or any part of the endocrine system has the potential to impact reproductive health. Next slide, please. And for today's discussion, when we're talking about the impacts on the reproductive system, we're primarily talking about exogenous agents that can be found in the environment that affect some part of the overall endocrine system that result in reproductive issues. And these slides or agents are typically referred to as endocrine active or endocrine disrupting chemicals, EDCs. So NIEHS and researchers developed key characteristics of EDCs by identifying actions of chemicals that interfere with hormone regulation. And what we've learned is on the next slide, please, that disruptions in the endocrine system can impact any of the target organs or glands. And endocrine disrupting chemicals in particular have been shown to be linked with developmental, brain, immune, and as I just mentioned, reproductive complications. The reason is because these EDCs are close enough to the chemical structure of the body's natural hormones that they can act or interfere in a multitude of ways. Everything from increasing or decreasing the amount of a hormone, mimicking, blocking, altering, or disrupting communication and or hormone processes in some way, shape, or form. Next slide, please. And if you think about our reproductive life cycle, disruptions in hormones or their processes can have detrimental effects, depending upon when the exposure of disruption occurred, because the reproductive system and its required hormones are involved in all or almost all life stages in some way, shape, or form. For women, it takes us from preconception to menopause. Our reproductive life cycle basically encompasses a complex cycle of continuous development and change throughout our lifespan. And therefore, any adverse impact at any of these stages can result in various types of reproductive toxicity, whether it's immediate at the time of exposure or cumulative because we're consistently exposed to a number of chemicals that could potentially build up, or even generational, where it impacts our young in some way, either say through malformations or impacts on their reproductive life cycle. Next slide, please. And we know that disruptions during the cycle can show up at any life stage because there are examples of this, such as exposures leading to infertility, metabolic issues, or even cancer that could have resulted from exposure as an adult, or could have been from an earlier exposure during puberty or childhood, or even exposure to the previous generation where your mother was exposed and the impact is on you. So the table here simply highlights some examples and effects of exposures and what life stages they appear. Next slide, please. And this is important because we've seen more reproductive disorders over the past few decades, and they affect millions of Americans each year. And some of these issues may be due to the changes or the impacts on the endocrine system that thereby impact the reproductive system, resulting in, say, reproductive issues or disorders that can range from pubertal timing to infertility to rare cancers in young women. Next slide, please. And so putting all of this information together, the concern is that environmental chemicals, especially those considered to be endocrine disruptors, may be playing a role in some of these reproductive issues. Next slide, please. Because these chemicals are fairly ubiquitous, and we know we're being exposed because over 70% of reproductive age women have detectable levels of chemicals and or endocrine disruptors in their system. And for some, these chemicals are found at higher levels because they may live in unsafe housing. They may live in areas that are closer to, say, landfills or Superfund sites, fields where pesticides are used, or maybe areas that are prone to flooding. Next slide, please. So when we look for possible explanations of these problems, we need not only take into account the exposures, such as air pollution, smoking, alcohol, the food we eat, and even the medications we take, but the various personal factors, such as, say, maternal stress, sociodemographics, weight and diet, exercise, geography, and even mental health. because each of these components plays a role in contributing toward potential health susceptibilities, such as infertility. Okay, I see people are having trouble hearing me. So let me just take one moment and see if I can switch my microphone. And
can you tell me whether or not you can hear me better with this microphone?
Yes, it's a little louder.
Much better.
Yes. It's a little bit better. Okay, all right, I'll go ahead and continue with this. So next slide, please. So the World Health Organization estimates that worldwide, 15% of reproductive age people are affected. But in the US, it's slightly higher with approximately 19% unable to get pregnant. Next slide, please. And infertility may occur due to male or female factors. It may be a combination of factors or even unexplained. And it's been associated with increasing age and environmental factors or lifestyle factors such as smoking, excessive alcohol intake, and obesity. More recently, we've begun to understand that the personal issues brought up on the previous slide, like physical and emotional stress, socioeconomic, racial, and ethnic status, and even environment, not just our personal environment, but environmental chemicals and pollutants that may all be contributing to reproductive issues like infertility in some way. Next slide. So bringing us back to our discussion on EDCs and their potential impact. We know that disruptions in female reproductive functions by endocrine disrupting chemicals may result in subfertility, infertility, improper hormone production, estrus and menstrual cycle abnormalities, anovulation, and even early menopause. Next slide, please. And these disruptions may be caused by compounds such as pesticides or components used to make plastics or drugs. We've even used drugs we've used and even metals, say, found in ground drinking water. And they can either subtly cause a shift in hormone levels, resulting in, say, a minor alteration in things like the timing of puberty, and to significant issues in fertility or alterations in specific developmental pathways. So while the outcomes can vary, the effects are detrimental for the exposed individuals. And one of the examples I have of this is on the next slide, where we talk about diethylstilbestrol, or DES. It is a synthetic estrogen that was used from the 1940s to the 1970s to treat women with high-risk pregnancies with the mistaken belief that it prevented miscarriage. So apparently I'm louder, but we still can't hear me. Am I speaking too quickly?
I can hear you. There's a little bit of a static once in a while, but I think you can go on. I think it's fine.
Okay, all right. So DES was used for about 30 years there with the idea that it prevented miscarriage, and that was not the case. Unfortunately, it was found that prenatal exposure to DES was linked to the development of rare forms of vaginal cancer in the daughters whose mothers took DES. And there were numerous other non-cancerous changes in both sons and daughters. For example, with daughters, it ranged from neonatal death, infertility, cardiovascular issues, endometriosis, and even uterine fibroids. So DES clearly demonstrated that exposure to exogenous estrogens during early pregnancy caused adverse outcomes, and these outcomes didn't manifest until exposed daughters reached adulthood. So while DES is no longer prescribed, about 10 million women have used it. So we're still kind of seeing the effects of it today and watching subsequent generations to understand the impact. Next slide, please. Another example of an exogenous agent that can affect developmental and/or reproduction is DDT. This is a pesticide that was used worldwide until it was banned due to its effects on wildlife and humans due to the ability to inhibit steroid hormone synthesis. And DDT and DDE, one of its breakdown products, are persistent organic pollutants that are found in the soil and sediment in countries today. Next slide, please. And both of these compounds interfere with things like testicular maturation and function and result in decrease in sperm quality in men. As well as in women, they can affect menstruation, gestation length. They can cause preterm births or spontaneous abortions, and even affect the duration of lactation. Mothers with high levels of DDT during pregnancy were found to be more likely to give birth to children that had autism or have an increase in birth defects. Additionally, studies have shown that DDT and DDE interfere with proper thyroid function during pregnancy and childhood. Next slide, please. And there's even concern with chemicals called parabens. These are a group of chemicals that prevent growth of bacteria, mold, and yeast used in cosmetics and personal care products, such as, say, lotions, sunscreens, antiperspirants, etc. And they're used to increase the shelf life and stability. Next slide, please. Because they mimic estrogen and they can enter the body through, say, dermal ingestion or inhalation. Next slide, please. And urinary sampling shows presence in people. And next slide, please. So at this point, there's insufficient data, but there is a concern that these may cause things such as abnormal breast cell growth or lower testosterone levels and sperm counts. And the heat map that I'm showing you here on the right is simply evidence of the presence of these urinary parabens and even phthalates, which is another chemical that is of concern, one that's widely used in, say, flexible plastics and consumer products. This heat map is basically showing concentrations in men with self-reported use of personal care products. So we know we're being exposed because we can see it in the serum, or in this case, the urine. Next slide, please. So it's not just the chemicals that have been banned that are causing issues, even though some are still in use in other countries. And some are even persistent in the environment for decades after I mentioned the DDT and DDE. But there are chemicals like the parabens and the phthalates I just talked about, as well as the per and polyfluoroalkyl substances, also known as PFAS, that are used in like coatings for things such as nonstick cookware and staining water-resistant fabrics and cleaning products, paint and firefighting foams. And these can all adversely impact development if exposed gestationally. Next slide, please. Interestingly, many of the health outcomes associated with PFAS exposure could be primed by that in utero exposure and subsequent fetal programming. So for this reason, there are groups that are interested in studying this early period of exposure, since pregnancy and in utero development are considered uniquely sensitive to environmental insults. So these groups want to understand if exposure at this stage is resulting in reproductive or disease issues later in life. Because the human epidemiologic evidence has associated PFAS exposure during pregnancy with things such as increased development of hypertensive disorders of pregnancy, things such as preeclampsia and gestational hypertension. And hypertensive disorders of pregnancy are then associated with an increased risk of cardiometabolic disease in the adult offspring. Therefore, researchers are interested in the potential relationship between in utero PFAS exposure, hypertensive disorders of pregnancy, and the subsequent metabolic disorders in offspring. Next slide, please. We at the NIAHS and others have been studying these environmental chemicals like PFAS and others to understand their effects on the mother and on the offspring. Next slide, please. And the findings increase in, and what we're finding is increases in maternal weight, as well as issues with the placenta and a reduction in nutrient transport to the fetus, resulting in intrauterine growth issues, as noted by the Blake publication in 2020. And then next slide. And we're seeing that in the offspring of these animals, metabolic and fatty liver disease, as was reported in the publication in 2020. Next slide, please.
Oh, I think we lost Dr. Sutherland. Could you just speak up a little bit?
Oh, no. Okay.
Oh, no, there you are. Okay.
All right. So Sue Fenton was kind enough to loan me these slides and then help me put together this big picture slide for this. And basically what we're doing is putting that data together to understand how these environmental exposures can cause maternal and fetal susceptibilities for health issues, or even cause disease by looking at specific mechanisms. Next slide, please. So we can prevent or address those outcomes. And for the female, those outcomes range from altered reproductive function, including reduced fertility, to metabolic issues such as glucose intolerance and obesity, and to impacts on other organ systems such as the heart with hypertension and stroke, or on the brain such as a reduction in cognitive function or altered behavior. Next slide, please. So the overarching concern isn't just that we're exposed to a chemical that could cause a problem, but that we're repeatedly exposed to a multitude of chemicals and agents and endocrine disruptors that in combination would increase our susceptibilities to reproductive issues such as infertility, or increase our disease susceptibility for the disease susceptibility of the next generation. Next slide, please. So as I mentioned before, there are a number of factors that can impact things such as fertility. And for my part of the presentation, I wanted to highlight that it's likely not just the personal factors such as age, lifestyle and diet, nutrition that play roles, but also our socioeconomic, racial, and ethnic status, where we live, what products we use, and what type of stress we're under, and how often, as well as the potential environmental chemicals that we're exposed to. Next slide, please. So then there's the question, what can we do about it? How can we as individuals reduce the potential disease burden? And the suggestions range from reducing exposures, if at all possible, by potentially using less plastics, or at least don't heat your food in plastics. Limit the use of nonstick pans or overuse of consumer products such as fragrances, skin and hair, or cleaning agents that contain potential endocrine disrupting chemicals. And instead use basic cleaners such as vinegar and baking soda. I know it's much easier said than done, but even reducing the physical and mental stressors, if at all possible. Eating organic foods, less processed foods, and especially less pesticide use, whether it's in your personal garden or in the food that you buy from the store. And then of course, cleaning and dusting and vacuuming and washing your hands often with plain soap is just fine. Next slide. And then of course, the global considerations such as science and policy, not just worldwide, but in your country, in your state, in your city. Next slide, please. Because we know that there are factors beyond just our age or weight that are impacting our fertility. And the concern is that the potential cumulative effects of all of our exposures is contributing in some way to this issue. So I gave you some strong examples of chemicals that can impact our reproductive health. And obviously they're not all like that, but there are more chemicals that we can and have not tested that we need to do so. And so that we can understand if the majority of those chemicals will be fine, or if we know that there are ones like endocrine disruptors that are causing issues, especially at higher levels or with cumulative effects. So it's therefore important for us to understand what impacts they have on us and how we can mitigate those effects, because we want to not only improve our health, but the health of the environment and the reproductive health of future generations. Thank you.
Thank you so much, Dr. Sutherland. We really appreciate your presentation and the emphasis on how important it is that we reduce our use of these chemicals, which can have such harmful effects on our body, to include effects on reproduction. So next slide, please. It is now my distinct pleasure to introduce Ms. Angela Grassi from the PCOS Nutrition Center. Angela, go ahead and take it away, please.
Hi, everyone. Thank you for joining us today. And Dr. Sutherland, thanks for that great presentation. I don't know about the rest of you, but now I feel like I want to live in a bubble, a sterile bubble. Next slide, please. I am Angela Grassi. I'm a registered dietitian, nutritionist, and founder of the PCOS Nutrition Center. Next slide. Just a few items to disclose that I do retail supplements at the PCOS Nutrition Center. Next. So PCOS, if you haven't heard it before, it stands for Polycystic Ovary Syndrome, and it's actually the most common endocrine disorder in premenopausal women. It affects anywhere from 6 to 13% of women living in the United States. PCOS, despite being so common, is very underdiagnosed. It's underfunded. Unfortunately, it is one of the very last funded conditions from the National Institutes of Health. And because of that, we don't get a lot of research and grant money for research and treatment options. So we also see that PCOS is very undertreated. PCOS is the most common cause of anovulatory infertility, and it's a multifactorial polygenic disorder with variable phenotypes. So what it means is no two people are going to present with the exact same symptoms, and there's a lot of variability between the symptoms. PCOS doesn't just exist in premenopausal women, though. It doesn't just go away once a woman hits menopause. In fact, we know now that PCOS is linked to lifelong health risks that extend throughout the later part of life. Overall, PCOS is a condition of androgen excess, and androgens are male hormones like testosterone, and all women have testosterone, just like all men have estrogen. It's just their bodies are producing too much of it. Next slide, please. So PCOS is not new. It is an ancient disorder. We have medical records that date back to ancient times of women presenting with absent or irregular menstrual cycles, infertility, hirsutism, which is excessive hair growth, which is caused by elevated testosterone, and abdominal weight. So these are all symptoms that someone with PCOS might experience. And it's believed that perhaps these women had a biological advantage during the hunter and gatherer years when food was limited and life expectancy was shortened. They had the ability to increase muscle mass due to the higher testosterone levels. They do overall, people with PCOS have slower metabolisms and thus a less need for food. And they also may have had a reproductive advantage of having no or fewer children, which increased their survival rate. So PCOS could be a health protective condition, but of course, we're not in these ancient times anymore. Next slide, please. So how do we diagnose PCOS? Right now, there's an agreed upon criteria that says you have to have at least 2 out of the following 3. So the first is oligo or anovulation. So basically 8 or fewer periods in 1 year. The second is having clinical signs of hyperandrogenism, so high testosterone. So you might have blood work that shows it, or you can have signs on the body that can indicate high levels of androgens like acne, excessive hair growth, hair loss, and other dermatological symptoms like that. And so we see when we look at biochemical signs, we can look at a total testosterone, free testosterone, DHEA sulfate is the precursor to testosterone. These are all androgens we can test to see if they're elevated. And then the third criteria would be, do they actually have the presence of polycystic appearing ovaries on an ultrasound? And of course, PCOS is a diagnosis of exclusion. So we have to rule out any other conditions that might be causing, for example, high androgens or affecting periods. But overall, the diagnostic criteria is at least 2 out of the following 3 that I presented here. Next slide, please. So when we look at a transvaginal ultrasound, what we're looking at is these follicles. Even though PCOS is called polycystic ovary syndrome, they're not cysts at all. They're actually little immature follicles. The follicles contain the eggs, and they're usually immature, poor quality. We usually see a lot of them. There's a lot of follicles in PCOS, usually 12 or more, and they resemble this string of pearls. And they're less than 10 millimeters in diameter. And overall, the size of the ovary is bigger. So a typical ovarian volume of someone with PCOS is greater than 10 centimeters. Next slide, please. So to assess the degree of hirsutism, so the extra hair growth, we can use a Ferriman-Galway scale. And as you can see, there's different severities of hair growth. And the hair growth is in a pattern in the central part of the body. So we have the lip, the chin, between the breasts, buttocks, and back area. And that's consistent with the higher androgen levels. Next slide, please. So PCOS is associated with reproductive associations. Certainly we see problems with fertility and periods being irregular or non-existent, although you can have PCOS and have monthly periods. Most do not, but we also see problems with pregnancy loss, preterm and stillbirths, the polycystic ovaries I mentioned, and even a higher risk of endometrial cancer. Next slide, please. Despite being a reproductive disorder, we do see significant cardiovascular risk factors in PCOS, such as hypertension affects at least 50% of women, abnormal glucose metabolism, dyslipidemia. So that's usually characterized as the high triglycerides and low HDL, the good cholesterol, which you want high levels of HDL, the weight gain, and insulin resistance. Next. So PCOS itself is an independent risk factor for type 2 diabetes. When we compare women with PCOS to women without PCOS across the board at different matched up weights, we do see that people with PCOS have higher insulin levels. We also see a rapid conversion from impaired glucose tolerance to type 2 diabetes in people with PCOS. Data showing a 2.5-fold increased prevalence of impaired glucose tolerance and a 4-fold increased prevalence of type 2 diabetes. Next, please. So PCOS is associated with other diseases. For example, next, hypothyroidism and autoimmune conditions are common in PCOS. Next. Obstructive sleep apnea is highly prevalent in the PCOS population. And we actually see that the higher levels of testosterone affect sleep receptors in the brain. Non-alcoholic fatty liver disease is very common in PCOS, and it's related to the higher insulin levels. Cardiovascular disease, as I mentioned earlier. Gestational diabetes is believed to be higher in PCOS. We also see, as I mentioned, endometrial cancer is higher in PCOS, and as well as eating and mood disorders. Next. So when we look at the prevalence of eating disorders among the PCOS population, we do see a higher prevalence of eating disorders in women with PCOS. This study found 11% of women with PCOS had eating disorders compared to 7.6% in the general population, as well as a higher prevalence of low self-esteem and a higher prevalence of psychological distress. Next. And in regards to PCOS and mood disorders, next. A 6-study meta-analysis that involved 22 to 32-year-olds found, next, that the rates of anxiety and depressive symptoms were higher in patients with PCOS compared to controls. Next. They also found that 35% of women with PCOS compared to 10.7% of controls had depressive symptoms. And this was after adjusting for weight, family history of depression, as well as infertility. The study also found that 14% of women with PCOS compared to 1% of controls had anxiety symptoms. Next. And what's worrisome is that 8% of women had suicidal thoughts. So for this reason, the Androgen Excess and PCOS Society has published guidelines for healthcare providers that recommend screening all patients with PCOS for anxiety, depression, other mood disorders, as well as eating disorders. Next. So the big question is, what causes PCOS? And I think Dr. Sutherland brought up a lot of factors that could affect PCOS. Any exposure to chemicals, pollution, drugs, toxins, everything that she mentioned, stress, diet, can all affect fertility and could link to PCOS. We see an imbalance of the microbiome or dysbiosis being a factor. There's definitely a genetic component to PCOS. It tends to run in families. Chances are if a mother has PCOS, she has at least one daughter. If she has a daughter with PCOS, and it is higher in sisters. And another link is that fetal programming, whether it's exposure in utero to elevated androgens or perhaps elevated insulin or those endocrine disrupting chemicals. But overall, we do see excess inflammation in PCOS compared to those without PCOS. Next. So treatment options for PCOS, traditionally, if someone wasn't getting their period, there is an option that they could take oral contraceptives. This can help to suppress testosterone and some of those unwanted dermatological symptoms like acne and alopecia, and can help with period regulation. If someone's struggling with infertility, in the past they've used letrozole. We now know that letrozole, which is an ovulation inductor, is actually better, works better for PCOS than Clomid. And we also have the use of insulin sensitizers, which can help regulate periods and help with fertility. We also have anti-androgens, another medication that can help with lowering testosterone and helping with the hair and the acne. Next slide. But we do know that nutrition and lifestyle modifications are the primary treatment approaches for PCOS. And unfortunately, the optimal eating plan for PCOS has not yet been determined. So we really need to take an individualized approach when we're helping patients with PCOS, improving their eating. Some eating plans that have been shown to have favorable effects on fertility and to help with improving PCOS are next. Next, you can just go the next three if you want to. Balanced eating plans, modifying the glycemic index and glycemic load, modifying the carbohydrate amount or fat or protein amounts, as well as including anti-inflammatory foods. Next. So examples of antioxidant-rich foods, these are foods that have antioxidants in them, which help support cell health and can help reduce inflammation. It protects cells. This is antioxidants can be found in cold water fish like salmon, trout, nuts, avocados, whole grains, beans and legumes, fruits and vegetables, and even in green tea. Green tea is a great antioxidant. Next. And here's an example of a balanced eating plan. So this is just a guide, but it shows you've heard like half your plate should be those non-starchy vegetables. And these non-starchy vegetables have a lot of fiber and have antioxidants to help support gut health and help with inflammation. A quarter of the plate should be protein, and that really helps to balance blood sugar and insulin levels. And then the other quarter could be perhaps some starchy vegetables or whole grains. Again, the fiber really is helpful for inflammation and gut health. And then having some fat, though, again, those omega-3 fats are great for inflammation and can help fill you up and leave you satisfied. Next. Of course, it's not just nutrition that can help with PCOS, but we know that exercise is really beneficial, just like it is for anybody's health. Particularly for PCOS, it can help with insulin and metabolic aspects. It can help improve metabolism, help with inflammation, overall help with mood and body image and self-esteem. And we know that regular exercise can be really helpful for ovulation and fertility. Next. Sleep is also very important for PCOS. As I mentioned earlier, obstructive sleep apnea is much more common in this population. Lack of sleep can worsen insulin resistance. It can contribute to weight gain and mood changes. it does increase the risk for high blood pressure and diabetes and inflammation. And we do know that sleep affects fertility. In fact, this study showed that women with sleep disorders had almost a 4-fold higher risk for infertility. Next. So basically, diet and lifestyle factors work synergistically to support fertility and pregnancy and overall health in people with PCOS, and that involves good nutrition and supplements and vitamins, regular physical activity. We see both aerobic and strength training really beneficial for PCOS. Even yoga has been shown to reduce androgen levels, the testosterone levels. Sleep is so important. And if you do snore or you find yourself choking for air, ask for a sleep study. A lot of sleep studies can be done at home now. And then stress management is really important because we know that stress hormone cortisol increases insulin. It can contribute to inflammation. Mindfulness is a great way to help with stress, and learning other effective coping strategies like exercise or other things that can help to help manage the stress, because obviously stress is never going to go away. It's more about how we manage it. So it's all of these lifestyle factors working together. Next. So in conclusion, PCOS is a common and complex condition that is frequently overlooked. PCOS is associated with diabetes and other chronic conditions. And sustainable diet and lifestyle changes are effective to optimize health and reduce disease, and are the primary treatment approaches for PCOS. And that treatment really needs to be individualized, and it might involve a combination of healthy eating, lifestyle changes, supplements, and other medications. Next. To learn more about PCOS, I've listed some great resources here. You're welcome to visit the PCOS Nutrition Center, which has a lot of information about nutrition for PCOS and recipes. There is an association called the Androgen Excess and PCOS Society that has a lot of great position papers and information. Another source is the American Society of Reproductive Medicine, as well as the National Polycystic Ovary Association called PCOS Challenge. Thank you so much for joining me today.
Thank you, Angela. We really appreciate your overview of PCOS, a condition, as you point out, that affects a lot of women. And it's important to talk about these and other conditions that cause infertility, and to start talking about infertility itself, to start to lift that stigma surrounding it. So next, I'm very excited to introduce Ms. Dorothy Baum. She is the leader of the North Texas Branch Support Group of the Turner Syndrome Society of the United States. Dorothy, please unmute yourself and the floor is yours. You're muted still, Dorothy.
Sorry about that. Yes, my name is Dorothy Baum, and I am a member of the Turner Syndrome Society. Turner syndrome is a chromosomal disorder that when the female is born, she's missing an X chromosome. Turner syndrome results in a missing or incomplete X chromosome. It does require a medical diagnosis. It is a rare disease, and fewer than 200,000 US cases a year. What's interesting about Turner syndrome to me is that it can be diagnosed at birth, or it can be diagnosed in the late teens, early 20s, across the spectrum. I personally feel very fortunate that I was able to be diagnosed at birth. I am what they call classic Turner syndrome. And I was so symptomatic that it was pretty obvious that there was something going on in my body. I had lymphedema. My blood pressure in my legs were different, which indicated a heart condition, which is called a coarctation of the aorta. At the time, I was born in 1953. This was such an eye-opener because not many doctors knew about it. Turner syndrome was only around and diagnosed by Dr. Turner back for me to get that head start. At the time, they did not have a doctor certified in pediatric cardiology that could do that surgery in the Detroit area where I lived. So that surgery was put off. Children that are growing up, girls that are growing up these days, sometimes it's 2 months, sometimes it's a year. It just varies on what the doctor feels is appropriate for the patient. Lab tests, imaging always required. Turner syndrome is something that is chronic and it can last for years or be lifelong. Just like as the body ages, there's all kinds of things that may come up. One of the things that happened my first year of life, Turner's women are very susceptible to earaches. I had 14 ruptured eardrums my first year of life. And back then, believe it or not, it's a surprise to many people, the treatment for that was radiation. So that caused a side effect. In my 30s and 40s, they found nodules around my thyroid. And that thyroid ended up needing to be removed because I felt that I could supplement by the thyroid meds. And I'm fine. You know, there was no cancer, but you just never know. Other things is a short stature. I am 4'8". We have, again, in this day and age, we have growth hormone that the girls can do. Many of these 4 or 5-year-olds are giving themselves the injection with mom's supervision. And it's amazing. They're over 5 foot, which doesn't sound like much, but there is a difference. And so that's kind of exciting for us. We have a conference and all kinds of sessions are there for siblings, for significant others, husbands, spouses of women with Turners. And it's a very exciting time. I myself was married at 27. The marriage didn't last just because of who we are, not because of anything involved with Turners. It was never the right time to adopt or to foster a child as far as I was concerned. So that never came into my life. Because I was diagnosed so young, it was something that I personally always knew. And I guess with the help of my parents, focusing on education, focusing on me as a person, how I could develop and help in this world, that was a big factor. I personally sometimes have issues with, not being a mother on Mother's Day, that kind of thing. But I have nieces, nephews. I lead a normal life. I've had a full life. I worked for the American Red Cross for over 30 years. And part of that time I served overseas, as well as various places in the US. So it was a very interesting life. I met several people of interesting backgrounds, that kind of thing. So it was, and that's, the travel was one of the things that appealed to me. When I was about 14 was when they started doing tests to figure out when I should be put on estrogen. And they did a bone age test. And once the doctor saw, the endocrinologist explained to us that the bones he wanted to get all the natural growth out of me that he could, so that once I started the estrogen, the end of the bones would lock. And so therefore all my natural growth would be over. So he wanted to get all of that out of me first, so I could have as much potential growth as possible. And until I went into the probably mid-50s, I had monthly periods. They weren't at all heavy, but the fact was I did have the periods. My body changed from the time I started the pills. My family often mentioned that once I was on the estrogen, that they could see the features in my face change, more mature kind of thing. So that was interesting as well. But with the lymphedema, I had several foot infections in the beginning of the year, school year, basically because I would have saddle shoes, heavy shoes that I would wear, and the back of my heel would get infected because it had a blister and the blister opened. So that was interesting, and went to the doctor all the time to get a penicillin shot or whatever I needed to nip that bacteria in the bud. And I was usually out of school for about a week. So, but it just was a normal way of life for me. That's all I knew. And a lot of people have questions about, how did you tell your significant other when you met them and that kind of thing? Well, that's a individual choice. And there are a lot of people like myself that, for the most part, have lived as a single person, supported themselves. In our organization, we have everyone from doctors, lawyers, nurses, social workers, to even a court judge in Chicago. By the way, she's in her 80s and she recently got married. So we're all full of life. We all have a great time together. I guess the closeness of the society is that we all have something special in common that only we understand, kind of thing. And I would think it's the same thing with diabetes or other ailments that other people are experiencing that we have no idea about. But it's been a wonderful opportunity to grow and to be able to manage life on my terms, basically. I wasn't an all-A student, but I certainly got my bachelor's degree. I got my master's degree. As long as I can remember, I had an education fund. That was what my family focused on. So be happy to answer any of your questions. I certainly appreciate being included in this. And Monica, back to you.
Thank you so much, Dorothy, for sharing your personal story in terms of Turner syndrome, as well as your experience of infertility. I appreciate you being here today. And so now we would like to have a very personal discussion. And I'll introduce myself, and I'll let my colleague introduce herself as well as we begin this discussion on our personal experiences. So my name is Lieutenant Monica Geiger. I am the Regional Women's Health Analyst, and I sit in Region 6, which is in Dallas, Texas, and covers the states of Arkansas, Louisiana, New Mexico, Oklahoma, and Texas. And I have Turner syndrome. I was born with Turner syndrome, and I was diagnosed when I was in the 2nd grade. I was lucky enough to be born in a time where we did have growth hormone. So I took growth hormone, and I achieved the illustrious height of 5'2". And I'm going to pass it to my colleague, Chris, to introduce herself.
Hi, everyone. My name is Chris Woolslayer. I am Monica's counterpart in Region 3, which is basically the Mid-Atlantic states. I serve as the Regional Women's Health Analyst, and I can come to you to speak about my experience as someone with PCOS as well. I was one of those people who it took me 4 gynecologists to finally be diagnosed. We went through the standard ultrasound of your ovaries. I did not have a lot of cysts, so they kind of just said, nope, that's not what it is. Although I kind of had pretty much everything else that comes along with having PCOS. So it was really frustrating for me and confusing to not finally get that diagnosis, which actually came when I was trying to get pregnant. Although for a long time, I kind of knew I had it. Both my sisters also have it, which is something that Angela had mentioned, that it can kind of run in, I say infertility runs in my family. We were all very fortunate to actually have children, but all of us struggled. So I understand that piece of it. So do you want to talk a little bit about the stigma? Do you want me to go into it, or?
Sure, I can start, and I'd like everybody to chime in as you feel appropriate as well. And what I love about this group and this discussion is we have women who have known since they were very young that they were going to have issues having children, and then we have folks who were diagnosed a little later in their life. To share a little bit more about my story. I was, as I mentioned, I was diagnosed in the 2nd grade. My father realized that I wasn't growing quite as quickly as the other children in the classroom. And so he took me to the pediatrician, who brought me to a pediatric endocrinologist. And that pediatric endocrinologist was on top of it. And I got the blood test, and I was diagnosed with Turner syndrome. And like Dorothy, I've known since then that I would not be able to have children in the natural biological way. And so that is something that I've had to think about as I grow up and have relationships. I've had thoughts of you know, am I still good enough as a woman? Womanhood is so closely intertwined with motherhood. So it's those are questions that you ask yourself. And I think those are normal questions that people ask themselves in this society when they're going through struggling with infertility. And one thing is growing up, you know, this fact was something that I never talked about. In fact, right now, right here, this is the first time I've talked about my diagnosis in a formal public setting. And so, which was a huge step for me. And I hope to continue talking about it. because it's been a secret for so long, and it doesn't need to be a secret that there are so many women out there who are struggling with infertility.
Wow, Monica, yeah, that's really powerful. And I do appreciate you sharing it with all of us. I can add a little bit on to the sense of womanhood and that kind of stigma. I did struggle for a number of years to get pregnant. I was one of those people that was put on Clomid, which was probably not the best thing for me to get pregnant. But I did, fortunately, was able to have my children. But that being said, I mean, you know, it's totally okay if you don't want to have children. And we're at a stage now in society where it's not looked upon as unusual, but the difference is that some women may want to have children and can't, but may just present like, oh, children were just not something I wanted, you know, like, so I see, you know, you can kind of hide it, but I think it's always best to be honest. And another piece of, you know, as well as Turner syndrome, but also very much for PCOS is the idea, or the normative idea of what being feminine is. So you add in the excess body hair, the weight gain in the belly, you know, the hair loss on top of your head. So, you know, all of that kind of goes against the norm of what it is to be a woman in, I quote unquote, I say. So it's, you know, that's really a struggle, the whole self-esteem, body image piece of it. And then on top of that, we do have, you know, the higher instance of anxiety and depression, and people telling us, oh, if you just ate better, or if you just exercised more, you could lose weight. Well, it's not that easy for some of us. So, and you hear that from your doctors as well, you know, and it's hard because a lot of doctors are still kind of, I feel like in the fog about what PCOS really is. And then the last thing I'll just mention is the fact that, you know, we need to kind of take care of that mental piece of these issues, you know, like don't hide it, you know, don't keep it a secret. If you don't want to share it with your friends directly, there's different like Facebook groups and different websites that people with that shared experience are very active on. You know, keep in mind that these may not be experts or medical experts, but it's nice to have a sense of community. Yeah, so.
And I think that's one of the great things about the Turner Syndrome Society is it creates a community of women who are very similar and have shared similar experiences. And the biggest takeaway I want anybody who's listening to this to get is that if you are struggling with infertility, you are not alone. More people than we even realize have issues with infertility, and it doesn't need to be a secret. We support you, and we love you and accept you, and we want to be there for you. So please reach out. Any other closing thoughts from anybody?
So I just want to, my takeaway is, you know, I struggled a lot with doctors kind of understanding PCOS, or, you know, kind of saying, oh, you don't have that, or, you know, it's only about fertility. Well, it's a lot more than that. So if your doctor is not kind of getting it or making it click, you know, find someone better. Nowadays, this is pre-internet. Nowadays, you can actually Google and see if there's like a GYN who has a specialty around women with PCOS or Turner syndrome. So, you know, they're out there, and now you can actually find those people a lot easier than you could back in my day. We can move on to the question and answer, because I see that we do have a few questions that have popped up. I'll actually go with the one that was just posted. There are suggestions, and this is for you, Dr. Sutherland. Oh, wait, you answered it. I'm sorry.
No, I'm so sorry.
Go ahead.
I didn't send. I wasn't sure if we'd get to it, but if I did see the question associated with what chemicals cause an increase in cholesterol and triglyceride level. And for those that didn't just see it, I did answer it in the text. And it was really that there's quite a number of them. There's even suggestions I've read about potentially pesticides and stuff that could cause issues. But the ones that I put in the chat were that PFAS, we talked about that during the discussion. There's even thoughts that certain phthalates or parabens or phenols and stuff could have an impact on cholesterol, triglycerides, or the cardiovascular system directly or indirectly through, eventual obesity and stuff like that. So it's unfortunately one of those things where exposure, especially prenatal exposure, and then trying to track it and understand it as we age and have issues as we get older, such as infertility, trying to track that back and understand what the problems are and where they came from is extremely challenging. So that's why the animal studies and the cell culture studies are kind of helping us to do that. And then, of course, the epidemiological studies as well. I hope that was a little bit helpful.
Thank you. There was another question about what chemicals cause, what the effects on a fetus when a mom smokes marijuana. I'm not sure if that's your level of expertise, but.
So I've read on this, I haven't studied it at all, but I've read a little bit where they know that THC, or at least certain variants of it, can cross the placenta. And it's been linked with low birth weight or fetal growth restrictions, so essentially low birth weight, but primarily neurodevelopmental issues like cognitive impairment or learning disabilities, and even as much as things like depression or ADHD, anxiety and sleep disorders and stuff. So rather than calming the child down, it seems like the child ends up having more neuro issues of sorts that are problematic. And what I don't know about this is whether or not they've determined the dose, essentially, meaning how often, is it just you've exposed a child at a certain developmental stage for a brief period of time, or if it's all throughout gestation. So the recommendation from my understanding is absolutely do not do this while you're pregnant so that you don't end up with a child with some severe neurocognitive issues.
That's interesting you say that. I work with a state who has done a lot of work to reduce maternal cigarette smoking. Mm-hmm. And what they're finding is that women will stop smoking cigarettes, but then they'll start smoking marijuana, thinking it's more, from the earth. So yeah, they're working on that right now, but I think it's important to mention. Now, Angela, there was a question for you about speaking more about ruling out other conditions when being diagnosed with PCOS.
Yeah, I mean, it could be many things that could also resemble PCOS, like endometriosis. It could be a thyroid. It could be a pituitary tumor. So it's important just to rule those out because PCOS is a condition of exclusion. But you have to be your own advocate. If you have symptoms and you're not getting the answers, like you said, if you're not happy with your doctor, trust your gut, keep searching for those answers. There are really great doctors out there. And there's a lot of help and you're not alone.
Wonderful. And I also see Angela actually posted a question herself about websites that show products that are free of parabens or cleaner products. That's a great question.
I think that there are some sites out there that have, especially more consumer types of sites. I would have to actually look to see if I could find a specific one. I can't recall if I gave you references on any of the information I presented. I'll have to look at it and see if I could find something for you.
And that's actually a great note. We are going to be sending out the slides, recording link, and also a list of resources. And that's one that we can actually add to it because that email will be going out in a few days once everything gets downloaded and all that. So stay tuned for that. And also feel free to share with any of your colleagues. I think that's all the questions we actually had. Bill, can you just pop the slides up one more time? So we have a few more things to mention before we wrap it up, just a couple So again, I work for the Office on Women's Health out of HHS. They actually have two challenges. One I actually have in these slides, the other I'll include in our follow-up email. And these are, we call them challenges. And this one is around endocrine disrupting chemicals. And it's an innovator award where you can apply as a organization to get funding to kind of support this effort. Can you go to the next slide now? This is, again, an innovative program that addresses endocrine disrupting chemicals. And we want to make sure that we include the attention to racial and ethnic disparities in the exposure. And the goal is to find out what innovative programs are out there, see what's effective, see what can be ultimately replicated. And the next slide. So there's more information about it if you go to challenge.gov. And just put in endocrine disrupting and it'll pop up. And then there's an email there that as well that if you have questions about it. They're not included in this slide, but there's another challenge that we have. It's called Improving Maternal Health for Addressing Endometriosis, Fibrosis, and PCOS. And that's another one that we'll also share out when we share the resources. Next slide. And again, the evaluation is really important that we get some responses, and we really appreciate you taking those that minute to fill it out. So that's just, and that was listed in the chat several times. So you just click that link, fill the form out, and then we really appreciate it. And I think that's all we have. Actually, one more slide. Monica and I are including our emails here, and you also see them when we send out all the information after the webinar. But again, it's Monica Geiger at HHS and then Christine Woolslayer at hhs.gov. So thank you all. Thank you to the speakers. Thank you to the participants. We really appreciate your time and are so grateful for all that you do. Thank you, everyone.
Thank you. Bye.